there'll be some other people coming in.
On and off.
Another switch somewhere. Anyway, let's go ahead and get started. Welcome back for those of you who survived the first class. And I understand we have one visitor, so I don't mind people dropping in and dropping out. It actually works out pretty well. So today, last time we talked about metabolic disorders. Does anybody have any questions about last week in general? I mean, you've got my email address. You can always send me email questions. What I tried to do for each course is send out a little pre-class material, and I've tried to keep it fairly short with a couple little clips and maybe a longer clip. And then after the class, I sent out a handout which has what the pre-readings were, pre-class material was, plus recommended further sources for those people that want to sort of go into a little bit more depth.
Thank you for that.
Oh, you're welcome. And I also appreciate everybody that sent in their surveys. For those that haven't, go ahead and sending them in. I'm going to start looking through them in the next week, and it will help me plan the last 4 classes. So I want to make sure everybody has some input. Right now we're at about 60% return rate, which I consider pretty good. So for those of you who are in the 40%, if you haven't gotten the survey or your survey went to your spam folder or whatever those technical things that happen that I don't understand anything about, just email me and I can send you another one. I did want to backtrack and say something about childhood obesity and talk a little about some of the people who have taught me and who, so you'll at least see who I'm talking about at times. Childhood obesity, and I don't think, just scanning the room, many people in this room have children at home. Although you may have children out of home, and you've understood that those children are even harder to influence when they're out of home than when they were in home, right? But a fair number of you might have grandchildren who pop through occasionally. Childhood obesity is an adult problem, basically. I mean, the last administration before the current administration, I understand his wife, you know, how the first lady or first person or whatever is going to happen in the future always tackles something, and Michelle Obama's thing was childhood obesity. Didn't have much success with it because children don't decide on menus, shop, prepare foods, drive themselves to fast food restaurants, at least until they turn 16. And but the take-home message is setting a good example is the best teaching method. So we're going to get into a little bit of Doug Lyle's stuff. You may have already seen one video by him, and you're going to meet Doug here in a minute. But I sent out a video, which was this long presentation on how to lose weight without losing your mind. And that's a good video. But he talks a lot about changing your environment. We're going to get into that a little bit today, but we'll get into it more next week with the neurological conditions. Quality of life for children who are obese is about down where it is for children with cancer. Back in the 60s, there's a cartoon that I could dig out of my files if I wanted to. It's a cartoon of kids in the 60s, and all the skinny kids are making fun of the fat kid, and now the current slide is all the fat kids are making fun of the skinny kid. Okay. I feel really sorry for my pediatric colleagues because they're really dealing with adults, but their patients are the kids, and they keep churning out fat kids, partly because, well, at Kaiser Permanente, or where I work for the Permanente Medical Group, the current pediatric weight loss program is give them a pedometer and tell them to stop eating sugar. And all of you now know that sugar is not the problem. It's 1,800 calories per pound. It's part of it, but it's not the whole thing. And there are studies to show that kids here, although they get knocked down a lot for not exercising or having much activity, are just as active as the Amish are in Pennsylvania by one study as far as steps per day. They average about 15,000 steps. So it's not activity, it's not the sugar. So it's not surprising that since the Permanente Medical Group is blessing a program that hasn't been supported by science, that it's no more effective than they were. So this is Jeff Novick. He's the guy who you've probably seen some clips, and if you saw his calorie density DVD on weight loss, Jeff's an interesting guy. He was a chef originally, and then he went to work for Kraft Foods, and then he got hooked up. He finished his education and started going to conferences on nutrition and worked for the Pritikin program, Nathan Pritikin's program down in Florida for a number of years. He was a nutritional director there. Then he hooked up for an internship with John McDougall in 1995. He started giving presentations at McDougall's Advanced Study Weekends, which were twice a year weekends. And then he started working in the McDougall 10-day programs since 2008. He still comes out to Santa Rosa. I see him periodically when he comes out. And he is probably the best dietitian in the country. If I want to know anything about a science or anything, I email Jeff, and I get studies coming back. So you're going to still get some drips and drabs for some of Jeff's stuff as we go through, including the fact, I had a couple people approach me and say, well, you're a vegan, and I go, yeah, well, I practice a vegan lifestyle, but I'm not part of the movement, okay? I don't know what whole food plant-based means. I mean, every person I talk to who says they're on a whole food plant-based diet knows what they mean, but I've also had people come in and say, I'm on a whole food plant-based diet, but I have fish 4 times a week or something like this. So it means different things to different folks. Probably the best description of a healthy nutritional lifestyle would be whole plant foods with minimal processing, minimal SOS, which is True North, no salt, oil, or sugar approach. That's Jeff. This is Doug Lyle. You're going to get to know Doug a little bit more as we go along. He's an evolutionary psychologist and clinical psychologist by training. He works for True North, which is what we call Prison Heavy, which is 1.5 miles down from the McDougall program, which is in the Flamingo, which we call Prison Light. The difference is in McDougall program, they feed you. Breakfast, lunch, and dinner, ad libitum buffets. True North does medically supervised water fasting programs. So they feed you water, okay? But he works in both places, and he's also, now that he's retired from the prison systems, because he worked for the prison systems for a while, also while he was doing all this, his website is Esteem Dynamics, and most of the videos I'm going to show you clips to will take you to that website, and you can see the videos free. There are other videos of his there if you want to look at a few more. He's the co-author of The Pleasure Trap with Alan Goldhammer, who's the chiropractor who founded True North back in 1985. They've done about 19,000 water fasts since then. They have about 60 people at a time. If anybody's interested in doing that, let me know. I spent 2 weeks there. I did 9 days on water. It's very interesting, very interesting. I don't like to recommend or talk. It's like recommending a book. I don't like recommending a book without having read the book, right? So now I've done the McDougall. I haven't actually done the McDougall program, but I've worked there long enough that I know what it is. But I've done True North. So I wanted to add one assumption. Remember the 3 assumptions on the first course? Nobody gets out alive, everybody does 24 hours a day, and everybody's an experiment of one. Doug has taught me that we are a group of animals. We are group animals by our nature. There's status involved in all groups, and you're going to hear a little bit more about that as we go along. As a matter of fact, one of the, for the next class, I think his video on how to get along without going along will be recommended. Because, you can make your own decisions, but then you go out into the real world and you're dealing with family and groups and all this sort of stuff. So it's important. So, we're back to our topic, delaying death and avoiding disability. And if you remember last week, we crossed off a couple of these. We talked about chronic liver disease and cirrhosis, non-alcoholic fatty liver disease, and we talked about diabetes. This week, we're going to knock off cardiovascular disease and stroke. Medical care is going to be an ongoing part of our discussion, because if you can avoid chronic conditions, you can avoid medical care, and if you can avoid medical care, my industry can't harm you. And last week, disability, diabetes, we crossed it off. This week, we'll talk about heart trouble and stroke. And then next week, we will go into the neurological things like Alzheimer's disease, dementia, Parkinson's disease, migraine headaches, sort of central nervous system sort of stuff. Might even have a few things to say about ADHD. Arterial disease is very common. There are a lot of studies on this. But this is the sort of take-home message from what's called the P-Day study, which was published in '99. And what they did was they found otherwise healthy people who were 15 to 19 years of age who had died by trauma, suicide, homicide. By basically, they were in the prime of their life and they died by trauma, by some respect. And they did an autopsy on their aorta, the big blood vessel coming down off your heart, and also the right coronary artery. And in the 15 to 19-year-olds, they found streaking, cholesterol streaking in 100% of the aortas, and 50% of the right coronaries. But not only that, not only were there streaking, but they were already starting to be raised lesions to block the arteries. And then the 30 to 34-year-old was the other group they looked at, and by then there's 60% raised, 75% lesions, and 43% raised. So basically, this is a process that starts shortly after birth. Actually, there are studies to show it starts before birth. But this just gives you an idea how prevalent it is. And we've known about this for a while because, as you're going to see, we did autopsies on soldiers in Korea and Vietnam, and there's some. So we'll delve into that a little bit with coronary artery disease. But just to put this into perspective, blood pressure is a very interesting phenomenon. It's basically you're a heart. If you imagine yourself as a heart, and you're just basically a pump, and your job is to pump blood through 75,000 miles of pipes. And you're cooking along, and all of a sudden the resistance is going up downstream. You don't know why it's harder to pump. You just know it's harder to pump. So what's your normal response? You got a job to do, right? Increase your blood pressure. Right? Works out fine. So then people come into my office and they have high blood pressure, and I give them a pill that lowers their blood pressure, but that doesn't help the heart because they've still got a pressure. So the heart raises the pressure back again, and they come back to see me again, and their pressures are a little better, but they're still elevated. So what do? Give them a different type of drug. Now, when I first started with Permanente back in '78, there were only 2 classes of antihypertensives. Now there are about 5. And I put a pre-reading thing in for how Dr. McDougall treats blood pressure, which will give you a different perspective. It took me a little while to get used to that when I was working with John. But the arterial conditions are systemic. So today we'll talk about high blood pressure, coronary artery disease, heart failure, stroke. We aren't going to talk about aortic aneurysms or intracranial aneurysms, but they're both related to high blood pressure. And there is some data to support that inflammatory diets actually lead to the little aneurysms that often break in the 40s and 50s. We'll talk about macular degeneration when we get to vision later on, but today we'll hit narrow discs. Most of you who've been around for a little bit longer know that people shrink as they get older. So we're going to talk about that. Delve into briefly, these will be sort of quick overviews: sexual dysfunction, back pain, kidney failure, peripheral vascular disease, and periodontal disease. We'll hit Alzheimer's disease next week. So I want to distinguish between normal and healthy. I find myself misstating a lot, but my industry sets what's normal. That is what's healthy is set by healthy, free-living populations that are eating correctly and active. So this is a study you'll hear a little bit more about because it was actually a hearing study done in the early 1960s, but it's consistent with a lot of the other data from healthy populations. And the Maban tribe was in Sudan, and they ate primarily plants, a little bit of fish, but very little, millet, dates, corn nuts, orchid. There was no chronic disease. And as you can see, contrary to what I was taught when I was going through medical school and what I thought was reality, which was blood pressures typically go up as people get older. It would be natural that I thought about that because I was living in a population where people's blood pressures went up as they got older. And in point of fact, the control group that went along with this study was in Wisconsin, and you can see where it heads. This is their top value. So as your heart, you pump, and that first pressure wave that is sent down through your arteries is your systolic pressure, is the top one, right? And the lower number is what it drops down to as your heart is filling. So it's basically if you put a little catheter in somebody's artery and look at it's like a sine wave. Just goes up and down like this. You spend more time loading than firing. So your average pressure is about a third of the way up between those two. In other words, your average blood pressure is more determined by your diastolic pressure than your systolic pressure. As a matter of fact, there's something called systolic hypertension where the bottom number is low and the top number is high. The way to look at this is the compliance of the blood vessels, or the elasticity, determines more the high blood pressure. The resistance to flow downstream is more the low number. Talk about that more in a minute. But I want to make a distinction between what's normal and what's healthy. Now, back in the late 1990s, Robert Vogel came up with something called, it's an arterial test with flow-mediated studies. So what you do is you take a blood pressure cuff and you put it around somebody's upper arm, and you pump it up at least 10 millimeters of pressure higher than their top number. So you're basically occluding the blood flow to the limb for about 10 minutes. And you put an ultrasound device over the brachial artery, and then you let it off. And healthy arteries react and expand. Diseased arteries don't. So this is a way you can check how reactive the arteries are after a very acute intervention. So after a high-fat meal, there is less dilation at 2, 3, and 4 hours. So anytime you take a high-fat meal, you've affected your arterial flow and its reactivity for 2, 3, and 4 hours. The low-fat meal has no effect. And there's also 31% less dilation with olive oil, canola oil, and salmon at 3 hours. So it's a very, Robert Vogel, this was a breakthrough because we were able to see effects fairly soon on the arterial tree. It was very difficult to do that in any other way. Some of the longer term studies on food have been people over the age of 60 on mainly plants for 3 years, 14 over 2.5, 19 years, 20 over 10. Here's one for a year, between 40 and 69-year-olds, 9 and 5. And a lot of these patients got off their medication. These patients weren't involved with medication. So this is the only randomized study that's not, you don't see a lot of long-term studies. But the point of the slide is that it takes weeks, sometimes years, for pressures to come down. This isn't surprising. You know, Rome wasn't built in a day. You weren't built in a day. If you're messing up your arterial tree for 40 years, it doesn't turn around in 6 weeks, okay? Part of it does, but most of it doesn't. So we don't understand. Whereas last week, the reason I start off with diabetes is because we have a pretty good understanding of what messes up the insulin, at least at a level that clinically we can make a difference in our lives and stuff like that. Of course, the problem is we don't know what a healthy blood sugar is. We know what a healthy blood pressure is, but we don't know what a healthy blood sugar is. I asked Colin Campbell that question once. I sent him an email, and he came back and said, well, there aren't any good population studies on that, but we looked at the China study data, and for like 100 people, half men, half women, were otherwise healthy. It looks like the average temperature, average fasting sugar was somewhere between 45 and 80. And you know, I don't see people with those blood sugars fasting because I don't see healthy people. I mean, we really don't know. But as far as the mechanism as to why the blood pressure does what it does, we know when you decrease your body weight, your pressure will go down. We know if you decrease the fat in your body and also your meals, your pressures will go down. If you increase your fiber, it will go down. If you decrease your sodium intake, it will go down. If you increase your fruits and vegetables, and we don't know what it is, whether it's the potassium, magnesium, the antioxidants, or soy, we don't know. Those are all different factors that probably contribute to it, but we just don't know. So we've gone over some of the studies. We've talked about as you get older, your pressures don't necessarily go up. Now, fitness is important, okay? But I want to define fitness for you because we're going to get into various aspects of it and we'll get as we go along. Because I see lots of people out there eating poorly who are running on the bike trail. And it didn't work for Jim Fick, right? So there's aerobic exercise, strengthening exercise, flexibility, balance, and stability. Most of you may realize and remember when you were younger that you didn't think about any of this stuff, especially the bottom two, okay? But as we get older, these things become more important, and it's important because remember you're an experiment of one to figure out what it is that you want to accomplish for a goal. I mean, your goal may just be getting up and down off the floor with the grandkid. I don't know, it's an individual thing. But to design a exercise program to reverse what the current environment has done to us requires looking at each of these areas. We'll do that as we go along. Of course, as my strength and conditioning coach told me when I was talking to him about this the other day, he said the most important thing is just get people to move. And you'll find that when we get into back pain, a 30-minute walk every day, if you're capable of, as long as you don't fall or whatever, is probably one of the 4 basic exercises you should do for back. But keep your back in good shape and avoid problems. So exercise is important. The 2 studies that I looked at here, that I put up, this one study that was done for 60 participants with an average age of 58 over an 8-week period. They did aerobic conditioning, like walking fast, running, and bicycling, or progressive resistance training, where you're lifting weights. And they both improved the health. When you ask these people, do you feel healthier? Yep. More vital? Yep. Fitness? The people with PRT said not so much the aerobic, and the mental stuff was more up with the weights. They both tended to help the diabetic control. But based on what you learned last week, you know that this isn't going to cure your diabetes. You got to get the fat out of your diet and fat off your body. Now, if you're running a lot and you get fat off the body, that's a big step. But if you're eating a lot of fatty food at home, it's not going to cure your type 2 diabetes. It'll help it. Neither one had an effect on the cholesterol. The aerobic conditioning had effect on blood pressure, but not the training. The body fat change was about the same. And if you'll notice here, the weight for the progressive resistance training actually went up, which is, when you think about it, you've got muscle and fat, and if you start lifting weights, you put on some muscle, that's pretty good weight, especially if it helps you in your functioning, okay? Meditation is something people often do a lot. This gets back early in the 70s. There was somebody called, what was the name? There was a relaxation, Benson, Dr. Benson out of Massachusetts General put a book out called The Relaxation Response, where people were meditating 3 times a day. And it did have an effect on the blood pressure, about 5 and 5. It also decreased the heart rate. There weren't any change in any of the laboratory measures, cholesterol panel, fasting sugars, or your diabetes. It did improve the brachial artery reactivity, because this was done more recently, so he had access to the Vogel treatment. But this was particularly important in people with coronary artery disease. So meditation is a route too. You can go. And so it decreases heart rate and blood pressure and increases arterial health. I had to put a dog slide in because I had a cat slide just about the same stuff. Doug Lau, if you saw his presentation on how to lose weight without losing your mind, he says it's very suspicious. There are only 3 species that have a weight problem. Humans, dogs, and cats. And they all live in human environments. Okay? You take wild rats, they're thin. It's wild animals. So it's very suspicious that maybe there's something about the environment that's leading us on. The course is not focused on medication, but I want to give you my brief 10-minute tutorial on medication, I'm sorry. Now, this is sort of what drives your doctors. When you come in, you get a blood pressure, and he puts you or she puts you in a stage. Now, prior to 2017, the stages were normal, pre-hypertension, 1, 2, and 3. They got promoted in 2017. The net result of that is probably a lot of doctors putting people on a lot of medication they didn't put it on before. They weren't put on before. Estimate about 42 million people more on medications. But all the guidelines from all the organizations say you should do lifestyle first. And Dr. McDougall, if you read his letter, he doesn't treat anybody with pressures that aren't consistently above 160/90 with medication. Of course, John works in a situation where people come in and live, and they change their lifestyle and their pressures go down. It's a mood issue. As a matter of fact, the best published intervention for blood pressure ever published was out of True North Health, was water fasting. So two numbers that I would love to be able to share with my patients, but are hard to find because there is an NNT.com website, and you'll see that in your handout at the end of this session that I send around. But this is number needed to treat and number needed to harm. So how many people do you need to treat to prevent something is the number needed to treat. The number needed to harm is how many people will be harmed. So for stage 1, before it's 2017, stage 2, before now, the number needed to treat is infinite. There's never been a study to show benefit. The number needed to harm is 1 in 12. So everybody who gets put on medication with stage 1 or stage 2 hypertension, 39% of people stop their medication on their own, but about 1 out of 12 people are actually harmed by that. Now, these numbers are hard to get at because they don't sell drugs and they require different types of calculations. But the number needed to treat.com has done it for some groups of patients, and you can look those up if you're on a medication that may be there. The other thing you need to be aware of when treating blood pressure with medication is something called the J-point phenomenon. So if you take people with real high blood pressure, like diastolics, the second number above 110, and you start treating them, that's the first group that was treated. It was a VA study way back in the 70s. And you treat those people, and 1 out of 8 people will avoid a heart attack or a stroke. They have very high blood pressures. As the pressures go down, the number needed to treat goes up, and the amount of strokes and heart attacks that are prevented goes down as well. Does that make sense? So lower pressures, you get less benefit treating people with drugs. When you get down to a certain point, the strokes and heart attack rates actually start going back up again. Hence the J. It's better, levels off, up, starts heading in the wrong direction. It looks like if the diastolic pressure is less than 85, you're on the upslope of the J curve. In other words, people would come into my office, I'd give them medication, they'd go home, their pressures would go down. What I saw in the office did not necessarily reflect what was going on at home. So to take an example, 120 over 80, if people were to come in to me on 120 over 80 and they say, is this a normal blood pressure? I said, it's perfectly normal. Is it healthy? No, but it's normal. If they come in at 120 over 80 and they're on medication, I'm going to tell them it's dangerous because their second number is below 85. Does that make sense? That's the J-point phenomenon. Now, of course, there have been articles that sort of try and argue against the J-point phenomena. They're often funded by the drug companies or people who are on their employ or get their research from them. But so blood pressure on medications is not the same as blood pressures on no medication. Does that make sense? So people who are healthy aren't taking pills. Remember, we're talking about tertiary prevention, which is on medications, versus secondary, where you've cured the condition, or primary. So if you're running around with a blood pressure of 90 over 65, that's fine. If you're on medication, it's not fine. Okay. I'm a fan of home measurements. I told you about my home measurement test for body fat last week, the full-length mirror. And I also talked to you about run charts based on my quality improvement training. And just to refresh your memory, you've got run charts, which are basically just values over time. Specification charts are values over time where you've drawn lines that set some specification. Like your doctor may say, this is the line for diabetes, 125. If you're above it, you're diabetic. If you're below it, you're not a diabetic. If you're below 100, you're normal. Not healthy, we don't know what that is, but it's normal. Or if I've got a patient on metformin and they want to change their diet, I'll give them a run chart and say, look, if your fasting sugars start going below 120, I want you to stop your medicine, or I want you to half your statistical process control charts where you look at values over time, figure out their standard deviations and their means and stuff like that. That's a more sophisticated way of handling data. Most of the doctors don't understand any of that. I don't understand it. I just know where I have to go to talk to people who do understand it. But you'll often see stuff like, we talked about a little bit, I might have mentioned tampering. If you're going along in a complex system, you're going to see things going up and down on a regular basis. If it goes too far up, it's significant. If it goes, you need 4 values above the first standard deviation to make a significant change. So what we see in medicine is people who are on like Coumadin or rat poison for their atrial fibrillation or something like that, they're going along and they're within the parameters, and all of a sudden they're just a little bit out, and they'll quickly adjust the medicine. They shouldn't do anything because it's not a significant deviation. So, but for the point of here, if you've got a home blood pressure kit and you can check your pressures in the morning, you can chart it every day over time. And what you do is just put a little down hatch for the systolic pressure and a little up hatch for the diastolic pressure. And you can just see what it is. And you take that into your doctor. When you start learning how to look at these run charts, it's almost like looking at EKGs. Although it's a little bit more informative because the EKGs usually just, are going up and down. So this is Meals for Health was a program I told you about last week that I did here in Sacramento. It was funded by EarthSave International. We had 21 participants from the Sacramento Food Bank, and we brought them in, and I did physicals on them on Thursday and Friday, and they had an intense weekend where at the food bank where we fed them breakfast, lunch, and dinner and gave them lots of education and kept them happy and did some dancing and stuff like that. And then every week they would get education, and we provided food for them for a month. We gave them spices, food, and we got the results that we got down from the Google program. This is Ollie's story. Ollie was a South Sacramento Kaiser patient, actually.
Blood pressure when I was in my 40s. And since then, it was always high, but as I've gotten older, it was getting higher. And so my doctors were monitoring me. And I had been on that blood pressure medicine for over 22 years. This program done something for me that the medical industry couldn't do for me. This program done something for me in 4 days. 4 days, I was off of my blood pressure medicine. When I started it, and 4 days, we started April the 8th. April the 12th was my doctor's appointment. And I went in there, and she took my blood pressure, because it had been running like 160 over 104, and it was going up, and they had upped my medication. And then when I started this vegan program, it went down, it was 123 over 78. And she says, I think that the medicine that the doctor gave you is working. I go like, no, it's the food. And it really was the food, I mean, I've been searching for a long time. I spent a lot of money at the health stores. I really did, trying to find out what was good for me. I hadn't had pork in like 38 years, but I was still eating chicken and turkey and fish. And I wasn't doing too well. I was spending all this money on noni juice. I was spending money on spirulina, my calcium pills, all this money I was spending. And all I needed to know was that I needed to eat this plant-based, strong, density low diet. It was just so simple. And I'm going like, wow, I didn't have that one puzzle that was missing. And this is it, I don't see myself going back to ever eating the way that I was eating because of the fact that I'm medicine free right now, and I'm loving it. I'm loving it. I get up in the mornings and I can just leave my house. I don't have to worry about, oh, did I take that blood pressure medicine? No, I'm feeling good right now. I'm feeling really good.
She also lost 12 pounds, dropped her cholesterol about 40 or 50 points. They kept trying to put her on statins, which we'll talk about in a little bit. But she resisted that. It's hard for me to tell doctors who are practicing in the current systems that they're in what this sort of experience is like. It doesn't translate well, even when I bring in the clips and show them. You know, I get this deer in the headlight look.
What do they teach in medical school?
So the question is, what do they teach in medical schools? I don't know. I went through there in Middle Ages. I actually did get some nutrition, a couple hours, I think, but it was more vitamins and stuff like that, like scurvy and, you know, pellagra and things we know about, the deficiencies. The reality is that even if I had had an in-depth course in Georgetown in the early 1970s, we've learned stuff since then. So part of it is keeping up with the information, and that's the challenge. And the other challenge is making it clinically relevant. Most of your registered dietitians are taught how to do stuff in hospitals and stuff like that. They don't have exposure to this. I've had conversations with registered dietitians who tell me they can't, there's no way you can cure type 2 diabetes. I don't know what to tell them. I mean, what they're doing is you're not treating it. You tell them to count carbohydrates. That's stupid. I mean, it's just not informed. It's not effective. What can I tell you? I mean, so coronary artery disease is one small part of arterial disease. It's not like blood pressure that affects the whole body, but it's these arteries here. You've got a right coronary, a left coronary, and you've got main branches. And so we've got inflammation and constriction. That's reversible, that if we do it earlier, it's better, but arterial disorders is a systemic disease. So we're changing our beliefs around this, and I'm trying to show you what we know now. So we know that coronary artery disease is related to lifestyle. This is the incidence of coronary artery disease in Norway from 1927 to 1948. Notice what happened to it during the war? That's German occupation. That's armies coming through and taking all the concentrated food substances like the meat, the butter, and the dairy, and taking all the fuel, and people are walking around more. There is an alternative that's been put out, which is the Germans were probably the best public health educators the world has ever known. But nobody's buying that argument. And you can see what happened after the liberation, right? I could have put up another chart. The same thing happened in Cuba when the embargo went on. Because they stopped importing food, and they started to have to grow their own food, and they went through a starvation period. It's called the special period, for about 4 or 5 years. The Australians actually came in. It was Australians who came in and taught the Cubans how to plant and grow food in small batches. But they also experienced a marked decrease in both coronary artery disease and diabetes. And as I mentioned before, we've been doing autopsies on Korean War veterans. Average age 22, 77% had coronary artery disease, 22 Vietnam, 45%, young people, 50% early lesions. We know this thing is ongoing. That's the bad news. The good news is you can reverse it. The bad news is it just takes a little time. And the really good news is the inflammation can be reversed fairly quickly. That's why we were able to get away with taking people off their blood pressure medicine at McDougall within 8 days, because that by eating a non-inflammatory diet, by taking stuff out of the body that causes the constriction of the small blood vessels, then the pressures go down pretty well. It's the blockages, the cholesterol blockages, as you're going to see here in a minute, that take years to go away. So early on, we focused on the blockages when we were in the 70s. We just figured you got these blockages, right? That must be causing the problem. Then little things started to show up, like, gee, most of the heart attack occurs in vessels that are less than 50% blocked. So maybe there's something going on besides the blockages. So we started thinking about inflammation and tried to start figuring that out. So here's a
In healthy coronary arteries, the blood flows without obstruction. In diseased coronary arteries, a fatty substance called plaque forms in the artery walls, and as the disease advances, may bulge out into the path of the onrushing blood, blocking the oxygen and nutrients the heart desperately needs, and from time to time, causing symptoms like chest pains and shortness of breath. But heart attacks result more often from plaque that does not protrude into the artery itself, but remains hidden in the artery wall.
One of the scariest things about coronary artery disease is that it can remain silent for so long. You can have plaque buildup in the coronary that isn't causing you any problem, doesn't cause you any symptoms, doesn't even cause a positive stress test, but suddenly ruptures. It ruptures, it causes a blood clot to form, the rest of the coronary artery, the rest of the pipe suddenly gets blocked, and a heart attack occurs. And that's really the most common cause of heart attack. This is what kills people, often in the primes of their lives.
All plaque is dangerous, but some plaques are unstable, on the verge of rupture. Scientists are today trying to determine how to identify the unstable plaque, while doctors try and help patients minimize their risks.
I apologize for the sound. I'll get your question in just a second. I apologize for the sound. I went over to the screen to try and figure out how to turn the volume down. There are all these buttons. I'm looking for the volume buttons, and there's a knob on the screen. One knob. It's the volume screen. So you get, wrapped up in this technology. Question?
Can that happen in any artery, like even to the eye, not just the heart, but to the retina?
Yeah, I believe it can. It's mostly studied. The question is, can that plaque rupture happen in any artery? And I think the answer to that is probably true. Yes, it can. It probably only tends to happen in the larger ones, but it probably happens in the smaller ones too. I was listening to an NPR show on the way over, and it had to do with hearts, and some lady was on, it was Science Friday for those of you and they had one lady on who had actually re-engineered a pig heart or something, and the next person came on and was talking about capillaries, that the amount of blood that the heart requires is an incredible amount, and each heart cell has 4 capillaries feeding it. And that sort of threw me back a little bit, and then you start thinking about blockages and constrictions, and you start thinking about how systemic it is, and it raises some really interesting questions like yours. Can this happen in any vessel? And I think the answer is probably yes. It's just that if it happens in different parts of the body, it probably has different consequences. So we're starting to figure this thing out, there's something else going on. And then a bunch of guys, Fergat, Ignero, and Murad, won the Nobel Prize in 1998 for discovering nitrous oxide. Laughing gas, right? Who would have thought? This stuff disappears within seconds. It's very hard to study. And it took them a while to figure it out. It was actually discovered accidentally in 1978 in this guy's lab. They were dealing with aortas from rabbits, I think. And they found the substance, but they couldn't identify it. Darn thing goes away too fast. It's a very simple molecule. It's just a nitrogen and an oxygen. It's very hard to deal with. So they keep going on. They finally proposed that it was, in 1986, that it was nitrous oxide. And then they started looking around as to what this thing does in the body. It's manufactured from a non-essential amino acid, arginine, which is in all foods that you eat. And what it does is it dilates your arteries, so it improves the flow. It blocks platelet aggravation, which is clotting, so it tends to keep things from clotting. It blocks inflammation, and it also blocks smooth muscle proliferation, or growth of smooth muscle cells. So smooth muscle cells are the cells that line your arteries and constrict, and they can multiply and get thicker. So nitrous oxide has all these beneficial effects that we didn't even know about until the 1990s. And it gets a little bit more complicated, but I don't want to really spend too much time on the biochemistry of it. Just suffice it to say, we found it out. We now know a little bit more about it. It causes it's something you want to have more of, not less of. Let's put it that way. Then we found out about the inflammation. So your body needs 3 macronutrients. It needs carbohydrates for fuel. We talked about that last week. We spent a lot of time on sugars and glucose and fructose and starches. Protein, which we'll start to get into this week, but finish up mainly when we get back into cancer in the 5th class. You don't need protein though. You need essential amino acids, which are the building blocks of protein. And there's 9 of them that you can't make, so you need to get them in your foods. You can make every fat your body needs for membranes and all the stuff your body makes out of fats, but it doesn't make omega-6s and omega-3s, and those numbers relate to where the double bonds are on the fatty acid chains.
What does it make it? What did you just say?
Omega-6s and omega-3s. They're fats that your body can't make. And they're fats your body needs. They're essential fats. They're like the essential amino acids. They're just essential fatty acids. Back in the old days, we had ratios of about 4-to-1 of the 6 to 3. And if you look at some of the contemporary studies, most people with who are consuming a lot of meat are about 7-to-1. The vegetarians who also do cheese and eggs are about 10-to-1. And there's one study with vegans that were up to 15-to-1. You're going to see why this is a problem in a minute. These are the sources of omega-3s, the flaxseed, walnuts, green leafy vegetables, and sources of omega-6 are poultry, eggs, grain. Most vegetable oils, corn oil is very high in omega-6s. Most people don't eat straight corn oil, but they eat a lot of processed foods, and a lot of corn oil is put in the processed foods. The reason this is important is the omega-3s and the omega-6s go through the same enzymes to make the stuff your body needs. Bear with me for a second. So they're competing. So if you have a lot of omega-6s, you don't get much of this going on. If you get if you get less of this relative to this, you're going to get more. This is the anti-inflammatory, anti-clotting side of the equation. This is the clotting and inflammation side. So when you eat much more omega-6s, you're going to end up getting a lot of this. You've probably heard doctors recommending aspirin after you have heart attacks. That's to block this step down here at arachidonic acid it creates inflammation. That's all it does. Doesn't get at the upstream issue. You can still have lots of inflammation even though you're taking the aspirin. It's helpful. It's helpful. The studies have shown that. But it just doesn't address this whole cycle. So you want to eat foods that tend to have more of this and less of this. The reductionistic science is really interesting. When you start looking at all these little micro things that are going on in the body, we found out about TMO, which is a trans-methylamine nitrous oxide, which causes inflammation in the arteries. And basically you get it from ingesting dietary phosphatidylcholine, which is in cheese, dairy, eggs, fish, mainly shellfish. And you eat that, your body turns it into choline in the gut, gets absorbed by the liver, creates TMO, and you get the inflammation. So it's, here again, what you need to do to avoid all this stuff is pretty straightforward, but everything that keeps coming out from the reductionistic science, looking at the little factors biochemically, tend to point to the big picture. You remember the slide I put up last week where I had all the biochemical pathways? That was a very complicated situation. As we study more of this, we get more and more insight, but the stuff that keeps coming out just keeps reinforcing what we've known from population studies. So to drive this home clinically, the first study was 1990, and that was Ornish, Dean Ornish's study. And he had a small group of patients, 28 patients. Now these patients all had heart disease. That's the population he was studying. They've already committed to heart disease. That's why they were in the study. He put them on diet, exercise, and relaxation. The relaxation was 3 times a day, and the exercise was once a day, and they dropped their cholesterol down. 82% showed a regression of the disease over a 1-year period. They'd done arteriograms, so they could actually show that the blockages had gotten less. And the average was about 4%. Meanwhile, the control group who hadn't changed anything, were blocking up their arteries even more. The treatment group showed a 91% reduction in chest pain, The control group, 165% increase in chest pain from their angina. They were saving $30,000 per patient. That's why Ornish's program is approved for Medicare. So medical organizations can bill Medicare for an Ornish program. They just have to go through the Ornish certification of $8,000 or something like that to do that. So he published a follow-up study at 5 years, and they used some statins, but without statins with statins there was less progression, which is understandable. And treatment, 7% regression was the most. So the people that adhered to the diets the most over a 5-year period had decreased their blockage by 7%. Now 7% doesn't sound like a lot, but that's the radius of the tube. And if you decrease it 7%, you'd have to go back to whatever that equation was I learned when I was a chemical engineer about flow in pipes and stuff like that. But it's the cube of the radius, so that it's really significant. You may have heard about Caldwell-Esselstyn. He also used another study with 22 patients, and this is where he picked up the goal of less than 150, the magic number of 150 that people hear about. There's nothing magic about this number. It may come as no surprise to the women in the room that there have been no cholesterol studies on women. If a doctor is treating a woman with statins for cholesterol levels, there is absolutely no basis for that. I mean, it's just an extension of what we know. I mean, I think it's a fairly reasonable thing to do, and you should worry about your cholesterol. But there are probably people whose cholesterols will never get below 150 because they have a lot of good cholesterol floating around. And there are probably people with higher cholesterols that are never going to have a heart attack or a problem. We just don't have any way to predict that at this point. Now, there are rare conditions where people have really high cholesterols in their family, and those people probably need pretty aggressive therapy. But if you also take a good family history from those people, they'll say, oh yeah, my father and my mother, they died of heart attacks in their 40s. You know, it's their family history tree is like just a graveyard of people who died early of heart disease. But we do push the statins a lot. Now, you know, I've been around for a while, so I remember when we were treating high cholesterols with colistin, which was a binding agent that bind bile and drag cholesterol out of the body, basically, because your liver puts cholesterol in your GI tract and you reabsorb it. So that was our first treatment for this. Of course, that was before we even knew about good and bad cholesterol. I had to take some people off colistin because they had such good cholesterol once we found out about the good and the bad. And those were the days when we said that cholesterols of below 300 were fine. So we've ratcheted down our treatment guidelines a little bit as we've learned about this. So you can definitely see changes. This is just within 3 weeks. This is courtesy of Caldwell-Esselstyn, one of his patients. Before treatment here, and the red is where the flow of the blood is good. So you can see just on his diet alone, which is, he even excludes nuts, although he's starting to think about backing off on that a little bit and letting people have some nuts because they actually seem to be helpful in avoiding heart attacks. But he keeps all saturated fat out of the diet, which means there's no cholesterol, so there are no animal products, there's no saturated fats, tropical oils like coconut oil, palm oil, and things like that are out. And he sees remarkable improvement. The only problem is that his most recent study in 2017 that was published in Journal of Family Medicine, he took 200 patients, and I think 192 of them, something like there was no progression or no clinical significant events in any of the people that followed his diet. But what he didn't publish was he didn't know how many of those people were on medication. Because he's at the Cleveland Clinic and people fly in from their doctors and they get treated there and then they go back to their doctors. And he didn't track in the study how many people were on or off the drugs. So even though it's an impressive study and it works, there's no doubt it works, I don't have enough information clinically to put that into a practice with my patients. So whether you use statins or not is a call that has to be balanced against, remember, number needed to harm again, right? So when people were on statins, I would check their CPKs, which is an enzyme in the blood that reflects muscle inflammation. And they took 14 patients and they biopsied their muscles, and they had normal CPKs and they had no symptoms. And they found damage to the muscles in 10 of the 14. It's studies like this that make me wonder about things sometimes. There are other studies that showed that, and you can imagine if you're an elderly person and your muscles are being compromised, you might be a little bit more at increased fall risk and have decreased leg strength, and that's been shown. So you have to balance the advantages to avoiding this with the statins to some of the other problems you get. It's not straightforward because we just don't have the studies. Angina is when you've got those stable blockages and you go to climb up a hill and you're not getting the blood flow to that part of the heart you need, so your heart hurts, and then you rest and it feels better. But it's not getting progressively worse. You're not getting woken up at night. It's not coming when you're at rest or anything like that. It's not like a pending heart attack. It's stable angina. And they put a bunch of patients, a large number of patients, on a very low-fat, plant-based diet and strength training and stress management, basically an Ornish-type program. It's Fradioli's lead author, but Ornish was one of the sub-authors. And 75% were free of chest pain in 3 weeks. Or 12 weeks, I'm sorry. These are the people that account for about 90% of the stent placement in the country. And I wouldn't feel as bad about them getting stents in if they had been given this option first, but they're not given this option. And that's, I think, unfortunate. Now, if you, yes?
Where do statins come into all this? Because there's a lot of opposition to this kind of...
Well, yeah,
thinking.
statins, remember, statins are, they block the production of cholesterol, but they're also an anti-inflammatory agent. So they block that inflammation, in addition to keeping the cholesterol out of the blood. So it's a perfectly good treatment. It just comes with some downsides, and most people who are prescribed the statins aren't giving the options. I mean, we get 30 or 40% drop, 30 or 40 points drop in cholesterol in 1 week at the McDougall clinic, just based on diet, basically. And they're living in a resort. Yes, ma'am.
When you talk about inflammation, like the inflammation of the heart, are you talking about the heart itself or the vessels in
The
the heart?
lining of the vessel, the endothelial lining of the vessel.
Okay.
Now, don't get me wrong, inflammation is something your body needs. My 9-year-old grandson was up with my youngest son. They were having a birthday party up in Arnold, and he was sledding, and he started to go down a fairly icy thing, and the sled flew out from under him, and his face hit the ice before his, and he ended up getting, this was his birthday, right? Ended up getting like just some like a shave on his cheek. Now, his body uses inflammation to heal that. So I mean, these systems are there for a reason. It's just that if you injure the arterial lining with diet and less activity, you're going to have inflammation of that lining, which causes then constriction of the blood vessels and blockage.
Is that what the arterial sclerosis is the inflammation?
Most of the arteriosclerosis is the blockages. That's what is considerably talked about. And that's out there, and we've known about that for a long time, but the problems often come from the inflammation. So it's both. And here again, we've learned about this in the last 30 years between the nitrous oxide system and the omega-3s and the omega-6. All this stuff has been figured out, right? You know, we ought to take a big dose of humility with all this, because, you know, anytime you start thinking you know what's going on in a complex system, you gotta take a step back. Does that answer your question?
Yes, that helps a lot. Thank you.
Yeah, you're welcome.
An autoimmune type inflammation? Or
It doesn't appear to be an autoimmune type inflammation. It appears just to be the cholesterol gets into the walls of the lining, and the macrophages and the white blood cells sort of attack it. And that's where the inflammation comes in. And then it builds up, and then if it ruptures, then you get a clot forming, because it's, you know, it's the way the body reacts to that. Yes, ma'am.
How does stress affect blood pressure?
That's a good question. I don't, you know,
What was the question?
how does stress affect blood pressure? Clearly, I think your pressures go up anytime you're under stress. I know less about chronic stress. The fact that meditation will tend to lower your blood pressure tends to let me think, that there's something going on in there that's helpful. But you got to understand, I've also been around a long time, and we used to think stress caused ulcers. And the guy who proved that it was an infectious disease almost got ran out of his continent of Australia on a rail, tarred and feathered by the rest of the GI docs who were at the conference, who thought he was certifiably crazy when he floated the idea out that peptic ulcer disease is an infectious disease. And when I was starting out, we were treating Mylanta and milk, and we had all these, cream of wheat. That takes me back. But we've learned a few things since then. But stress is a factor, but I don't think it's as big a factor as people would often think it is. Okay, that's my own take on it.
How do you feel about fish oil supplements? You're talking about omega-3.
We're going to get to that. We got a slide coming up on fish oil.
Okay.
This is kind of going back, you were talking about, you said something that normal isn't necessarily healthy.
Right.
So you may have touched on this last week, I don't remember, but then how is normal defined, like normal blood pressure?
Okay, so the question is what is fine, normal versus healthy?
No, how is normal determined, like 120/80 or whatever?
My medical industry, so normal for fasting blood sugars used to be 150. If you were above 150, you had diabetes. If you were below 150, you didn't have diabetes. And it got lowered to 125.
No, it's 100.
So the medical industry defines what is normal.
Based on what? How did they come up with that number?
Expert consensus panels, which are not very reliable ways to come up with things. Because often expert consensus panels, this is probably not news to anybody in this room who's been around for a while, if you look at government panels that come out with recommendations, it's a little bit like the Paris Agreement. I mean, 1.5 is fine. You understand that's not going to, it's only going to lower the possibility of human extinction, not eliminate it. So they're politically driven, they're influenced by outside efforts. I was involved in a lawsuit against the FDA, or the agriculture department, I don't know, I was one of the 4 docs that was on the suit. And we were suing because when they were coming up with the nutritional guidelines, they wanted to drop cholesterol as a nutrient of concern. So PCRM, who initiated the lawsuit, looked at the backgrounds of everybody that were on the committee that made that recommendation, and the chair, who was the moving force behind that recommendation, received all her funding at Tufts University from the Egg Board. So the suit never made it to court. They dropped, they settled, they took that line out, we did away with the suit. So, but just to show that I'm still making trouble in my old age, I am now actively part of a PCRM lawsuit against the state of California. Picked out the U.S. government, why not go after the state? Processed meats have been labeled a class 1 carcinogen. And it's still being sold in public school. So we're still feeding our kids class 1 carcinogen foods in our public schools. And so the lawsuit is against the state of California to list processed meats as a class 1 carcinogen as required by Prop 65 or something like that. Now, when that hits, when they agree to do that, I mean, it may be in the courts for how long the courts are. Nobody benefits. The kids will be, some of the kids going into first grade will probably be out of high school by the time the lawsuit gets settled. But so that sort of stuff's going on. But the normal versus healthy, you're better. It's a sort of a spectrum. You're better off healthy than normal. Like I said, I don't consider 120/80 healthy. Maybe normal by the standards.
What do you consider healthy?
About 110 or 115.
Over what?
Over 65 or 70. But it's individual. The problem is none of us in this room have been eating and active for our entire lives, eating right and active for our entire lives. So we've developed some arterial disease. I mean, if you look at the spectrum, the first thing that happens is nonspecific back pain in men in their 30s. And then you get sexual dysfunction in women in their 40s and men in their 50s and 40s. And then you get heart attacks in men and 50s, and heart attacks in women in their 60s, and strokes in men in their 60s and 70s, and Alzheimer's in their 80s. It takes a while for this arterial disease and its related conditions to catch up with you, as you're going to see. So this is one case study I wanted to show. We're going to take a break here in a minute. Joe Crow was a 44-year-old surgeon at the Cleveland Clinic. No family history, overweight, non-smoker. He wasn't overweight. He had no diabetes or hypertension. He exercised. His cholesterols weren't all that bad. And he developed chest pain when he was operating. So they studied him, and they found this blockage here in his left anterior descending artery. It was too small to put a stent in. So they kicked him over to Esselstyn, who was a friend of his, and they put him on a diet. And after 2.5 years, he was operating again, his pains went away, and he started feeling funny in his chest, so they figured they better study him again after 2.5 years, right? It was open. He had opened his coronary artery up in 2.5 years. So, whatever he was feeling in his chest was not due to that. It was muscular or something else. So basically, cholesterol, saturated fat in your diet is converted to cholesterol. We now know a little bit about the nitrous oxide system and the inflammation. Olive oil is not a health food. It is it has less saturated fat. Canola oil has a less saturated fat, but the coconut and palm kernel oils and things like that have much more saturated fat than butter does. So coconut oil isn't the latest health food. But olive oil, you can avoid olive oil as well. You just have to learn to water saute. Let's take a break. The really big issues, which were the blood pressure and we covered the blood pressure and the coronary artery disease. The good news, by the way, we have a microphone. The bad news is the batteries don't work. So the really good news is between now and next time I'm going to try and come up with a microphone that works, or bring AA batteries to plug into that one and hope it works somehow. So the people in the back of the room are having a little hard trouble hearing. We'll get to hearing by the way on the 6th class, unfortunately. There's good news and bad news there, as you can imagine. But we hit the blood pressure and the coronary artery disease, which are the two big ones, just to drive home some of the concepts. We're going to go through some of these others fairly quickly because there's limited time, but also because there's limited information. So atrial fibrillation is an interesting condition. Basically, you have a node up the top of your heart that beats and sends electrical impulses down the whole heart. So it starts at the top and sort of constricts down. So you've got the two atrium at the top, which beat before the big ventricles at the bottom do. They're like the primer pumps. So your atriums are primer pumps for your ventricles. And your right ventricle got the easy work. It only pumps to the lungs. The left ventricle pumps to everything else, just to show that life isn't fair, right? We know that in populations where they eat right and are healthy, like in the blue zones and stuff like that, you don't get much atrial fibrillation. But it is the most common cause. And what happens is the atriums fibrillate. Instead of getting a steady 60 beat per minute on average sort of pulse coming down, it sort of fibrillates and starts sending 360 beats down to the ventricles. And the poor ventricles just can't respond to that. Try as go as fast as they can, so what you get is a very fast, irregular pulse, and that's atrial fib. And what that means to you functionally is you lose about 10% of your cardiac output. In other words, you lose your primer pumps, basically, for your ventricles. So you've lost 10%. Now, most people tolerate that pretty well. Some people feel like when it's going that fast, they got like a rabbit in their chest. And it's probably not good to run your heart at about 130 or 140 beats per minute constantly. So we put people on medication to slow that up, and the medication sort of blocks. It's sort of a medical block between the top and the bottom. The problem that people take medication for, in addition to rate control, is when these things are up here just fibrillating like this, there's a tendency for them to form little clots in there. And they break loose and they go downstream. and they cause problems depending on where they go. So they go downstream and things get big, smaller and smaller, and then they stop, and you get no blood flow down below that. Now, if that's a coronary artery, that's like a heart attack, right? Blockage of an artery that actually creates no blood flow, and then the muscle dies. But if it goes to the brain, it creates a stroke. That's a particular type of stroke called an embolic stroke, where you've got an embolism that goes up. If it heads for the kidneys, it knocks off part of the kidneys. If it heads to your big toe, you get your big toe. So we've gotten really sophisticated with our technology, and they can map these electrical circuits now. These electrophysiology cardiologists go in there and they can map these things, and they were trying to figure out ways to chemically block it so that people don't have to take the anticoagulants. And the ablation was showing promising results, but they're backing off that a little bit. This is way above my pay grade, but I did hear a guy from Louisville who is an expert in this. Yes, ma'am.
Is that the only reason somebody I just was in a setting where this happened, somebody might say, oh, my heart is racing? And is it dangerous? It happened in a group setting. We wanted to take her to the hospital. She refused and she drove herself. So how risky was that?
Okay, so when you have a heart attack, it occurs inflammation. It's the actual arrhythmia that usually kills you. Because not only does the atrium fibrillate, but the ventricle fibrillates.
And that was what was happening when she said...
I don't know. Without a cardiogram, I couldn't diagnose her type of rhythm.
Okay.
She could have dropped into atrial fib, which wouldn't have been dangerous to her, particularly. It could be, there are in younger people mainly something called paroxysmal ventricular tachycardias, where all of a sudden they just get fast heart rates. Those people do really benefit from ablation, but it tends to be a younger person's disease. This typically occurs in older people,
She's 65.
more expensive people. It's the most common arrhythmia.
What's ablation?
Ablation is where they go in and they kill part of that electrical circuit. They go in there with a wire, and it's sort of like putting a stent into an artery to open it up, except they try and figure out what's causing the fibrillation is these reentry circuits where it keeps going back and forth, and they try and figure out what those are, and they cut them off. It's like cutting the wires. It's fancy, but it's like a lot of, remember the Operation Cat Drop?
Yeah.
Long term, there are sometimes some unanticipated consequences, or the FDA approves something based on 2 or 3 weeks worth of data, and then all of a sudden they start doing it across the country, and people start going, wait a second, this isn't working out quite like we thought, so that's what ablation is. Yes, ma'am.
Can a vegan diet the electrical circuit treat?
I don't know. This may be one of the horses out of the barn situations. And here again, I'm not preaching vegan diet. That tent is big. But healthy eating and activity and all of it together, I don't know if it'll reverse this, but if you have this, you don't want anything else on top of it, like heart attack. Now, my thinking on this, and I've never seen this proposed, although I'm sure somebody's thought about it before me and published it, because these people write all these papers and stuff like that, is that why would this happen in some populations and not other populations? That's like the cat and dog and human being fat situation. I mean, there's something there, okay? Who knows what it is? It could be some chemical in the environment. It might just be lifestyle. It's also possible that all the little small vessels in the heart that we can't see blocked may have blocked something that caused that sort of thing to go on, or a little inflammation. Who knows? This is one of those mysteries that maybe they'll figure out eventually. But from the standpoint of eating right, I think you're better off doing that. I do know that the guy from University of Kentucky at Louisville came and speak at the Advanced McDougall Study Weekend a while ago. I met him, I forget his name, but he was using dietary intervention to help people with AFib. One thing I do know about AFib, from based on 2 patients, is hydration is an issue. So, you go into the ER and they put an IV in, they slam you with a lot of fluid. Sometimes it just reverts, but sometimes it doesn't. And there's two different types. There's intermittent where people pop in and out of this stuff. And once sometimes you're in it, you're in it. And those are different things. And it's not as clear medication usage for the intermittent versus the, so there's a lot of confusion. Yes, ma'am.
So are you saying that atrial fib is different populations? Is that another thing we might not see in Africa, for example?
Yeah, right, exactly. In populations, the study I'm thinking about was out of Nigeria, I think. There was no atrial fib there. And it's, when you start seeing difference in populations, like no colon cancer in Africa versus here, prostate cancer is very low in Japan and very high when the Japanese move to this country, you start getting really suspicious that something's going on. But as you'll see next week when we talk about some of the neurological disorders, the timelines for this stuff catching up to you can be a long time. And sometimes when it comes, or it can't be prevented. You know, the horse is already out of the barn, water's over the dam. So that's where we start talking about the precautionary principle. And the problem is, as a doctor, if I get a patient to do something right in their life, I don't know what they're preventing. How would I know? It's not going to happen, right? I don't know how many people don't get rheumatoid arthritis or don't get a coronary heart attack because they do something right. I don't even know what would have happened to me if I hadn't changed my eating habits when I was 13 years ago when I was 58. I don't know. But large medical organizations, not to be named, who have large populations can look at population data and say that people that do this don't get this. So there is a place for large population studies, I think, to sort of support the precautionary principle. That doesn't keep us from learning from large healthy populations. As long as you're willing to jump over the hurdle of its correlation, not causation, you know. And that argument gets bandied around a lot. But quite frankly, there is no good data on atrial fibrillation treatment with lifestyle. So, but I would certainly think that lifestyle prevents it. Yes, ma'am.
I had a couple of people who had that. One was a 25-year-old, and one was an older person, but they stopped the heart. They couldn't get it to stop, so they had to stop the heart and then restart it.
Yeah, actually, what you're talking about is where they use the paddles to shock the heart to stop it, to let it reboot. You know, I think the rebooting probably works better in the young than the old, but pure bias on my part. I would be surprised if a 25-year-old had atrial fibrillation.
He drank a lot.
I mean, and drinking is associated with atrial fibrillation. Alcohol consumption is, but there are a lot of arrhythmias that are also associated with that, and they can be pretty dangerous. And we have very good treatments for some of this stuff, but this is more the chronic ones that we get as you get older, and things like that. Other questions? So stroke is a little bit like a heart attack of the brain. In other words, you lose blood flow, and that's in the heart. That's almost always a clot that forms, as you saw in the video. But it's also for the head. It can be embolic, like an atrial fibrillation clot breaks loose and gets up and stuck on a block, so it stops the blood flow. Or it can be hemorrhagic, where one of the blood vessels actually breaks. That's usually associated with high blood pressure, the hemorrhagic strokes. And the ischemic are sort of like the coronary artery disease strokes you get. Like I think the question the gentleman had in the back about other arteries, that's an example of another artery, sort of a, heart attack of the brain, so to speak, another type of artery. TIAs are interesting because they're transient ischemic attacks. These are things that are like strokes, but they resolve within 24 hours. And I don't know what the current literature is on that. I've been retired for too long to keep up with it, and I didn't even know when I retired what it was. But my thinking at that point, based on what I knew, was it was more like little platelets or minor little clots that then dissolve. Because your body's always clotting and unclotting. I mean, when you cut yourself, you want your body to clot. I mean, that's actually a useful phenomenon. But it also has to get rid of the clots and unclot. So there's this constant balance going on. It's like your body hurting itself and then healing itself. Congestive heart failure is usually, the heart doesn't work as well in congestive heart failure. You're actually not putting out as much blood as you need to. And usually you've killed off part of the heart muscles, or your heart has been working at high pressures for too long, so it just gives way, or you've lost like 10% of your cardiac output, or your valves are messed up. You actually have valvular disease. That's another, remember you've got a valve between the atriums and the ventricles in the outside world. So if any of those valve problems, like the aorta gets a stenotic, which is a congenital problem with two leaflets, or you get an infection in the mitral valve after strep infections. That's why we treat people with penicillin who have strep infections. Excess alcohol is also another cause of cardiac, problems. Remember Bob Dole in the chamber? I mean, I think he probably wanted to be remembered for a lot more than himself, the golden retriever. But a lot gets made out of male sexual dysfunction, but women sexual dysfunction is also correlated with cholesterol levels. So I wanted to just sort of equal the equation out there a little bit. Men with erectile dysfunction in their 50s are very highly correlated with people that have heart attacks at a later time. Periodontal disease, gum disease is associated with saturated fats and cholesterol. Here again, saturated fats are made into cholesterol. So people who eat more plants and less animal products and less saturated fats tend to have less periodontal disease. Kidney function. Okay, so I'm in an industry that people would see me all the time and I'd check their kidney function, their creatinine, and that would allow me to calculate their glomerular filtration rate, how well their kidneys are working. So normal is over 90, and we got all these stages. Does this sound familiar? And when people got up to about this stage, they would have me refer them to a nephrologist. And the nephrologist would then put them on a low-protein diet. Raises the question of why did we wait till their kidneys were gone to put them on low-protein diet? But nobody asks questions like that, why not? So animal protein is a toxin to your kidneys, period. It appears that animal protein is a little bit more of a toxin than plant protein. And now animal protein does differ in some respects from plant protein. There's more methionine and branched chain amino acids. Both those are essential amino acids. They're a little bit more prevalent in animal protein than plant protein. But the other thing, you can't look at just the amino acids in the protein. You've got to also look at the whole package. Remember I talked about fruits in the last lecture. If you give people fruit that has glucose, fructose, and table sugar in it, it's sweet. That's why we like fruit. But it doesn't come into the body as quickly if you eat fruit versus Coca-Cola or soda with a lot of sugar in it. And it's not the fiber in the fruit, it's the phytonutrients that seem to keep it out. So it comes in slower. The same thing may be happening. It may be the difference. It may be the methionine, which is also associated with cancer. We'll talk about that later. And branched chain amino acids, which are associated with diabetes. That may be the causation, or it might just be the whole package. I don't know. I don't think anybody knows at this point. This was a little bit more surprising to me. Phosphorus is very deadly to the kidney cells. Now, where would chicken get phosphorus? Chicken doesn't have phosphorus for the most part. Anybody buying chicken in those little packages? What do you think the liquid is around the chicken? There's a name for it. It's called spurge. It's a phosphate preservative. Okay? So they put phosphates in cheese, fish, and it's in soda too. I mean, the reason I don't drink soda has less to do with the phosphorus, although this is like icing on the cake, and more to do that 2/3 of the sodas in the community when last sampled had benzene in it, and 32% actually failed the federal state benzene standard intakes for daily intake. Benzene is a carcinogen associated with bladder cancer. So that's the reason I don't drink sodas. So kidney function is another one that's associated with arterial disease too, because the arteries can get blocked up and not blood flow. Yes, sir?
Is that Is that more in the dark colas than the light colas?
What's that?
Is that more in the dark colas than the light colas?
Dark colors? Oh, I don't know. No, what happens is the sodas are put in, they put benzoic acid and ascorbic acid. Ascorbic acid is vitamin C. Benzoic acid is a preservative. If it sits long enough, those two things will form benzene. So I think it's in all sodas, actually. And probably sodas that have been sitting around longer. Now, there are a lot of myths around protein, and we always get the protein question. There's absolutely no way you can have a protein or amino acid deficiency given adequate calorie intake. The IRA prisoners that died of starvation on an average of 80 days, thereabouts, had plenty of protein on their body at autopsy. They just had no fat. And since your brain is about 25% fat, they had cannibalized the fat in their brains and had problems with their immune system. So they died of infections for the most part. We need 8 essential amino acids. The complementary stuff was debunked. That was hot in the 70s.
What is that?
They're talking about combining certain foods like beans with rice and bean corn, because plants don't have a complete amino acid profile. But if you look at the essential amino acid profile of eggs, asparagus, and broccoli, they're identical. So the only difference is that it's more concentrated in the eggs because there's less fiber and water in the eggs. Human breast milk is 5% protein. That's the ideal food for babies when they're growing as fast as they're ever going to grow. All they need is 5% of protein. And that's only 38 grams of protein on a 3,000 calorie per day diet. So you don't need protein.
Can I ask?
Sure.
What I read though, as we get older, we are more prone to losing muscle mass, which does have something to do with the intake of protein.
So the question relates to losing muscle mass related to your protein intake in our more experienced citizens, right? I think that has more to do with the lack of activity. Because I think if you use your muscles, you will build your muscles. And there may be some literature, and I'm not aware of it, for a higher protein intake if you want to build bigger muscles. Not functional muscles necessarily, but just bigger muscles. So for those experienced citizens that are into bodybuilding and competition, there might be a place for protein supplementation. But for average person, it's not an issue. Yes, sir?
The various plants that are at the fourth point each have a percentage after what is the significance of that percentage?
That's a percentage of protein in those substances. Here again, it's not really concentrated because of the fiber in the water, but just to give you a sense, people often say if I'm eating this sort of stuff, I'm not getting enough protein. But if you ate nothing but potatoes, you would get 8% protein intake, which is above the 5% you needed when you were a newborn, based on mother's milk.
Earlier you said something about 9 essential amino acids.
Yeah, some people say 8, some people say 9. There's a sort of, I forget which one it is, but there's one that's essential at times and not other times. So you'll see either 8 or 9 essential amino acids. The amino acids are the building blocks of protein. The trick answer to the question of where you get your amino acids, your own body. Because you got to remember you've got protein in your body that's being broken down by your body, and it's being broken down into amino acids. And if your body sort of needs certain types of amino acids, it's got a pool to pull from. It doesn't need to be replenished. It does over time need to have the essential amino acids, but here again we're talking time-wise. That's a good question. Thank you. Yes, ma'am.
So the asparagus with 42%, it may not have all 8 essential though, right?
Right. It may not have, it probably does have all the essential, just not in the same profile as others do. But if you eat a mix of food and you eat adequate calories, there's no way you can not get the protein you need or the essential amino acids. Just not an issue. There's never been a case of protein deficiency reported in the history of the world given adequate calorie intake. When I was doing a rotation in medical school in the Bahamas, we would see kids with kwashiorkor because of low calorie intake. And that's often been published as protein deficiency, but it's more the calories, less the protein.
Does protein help build bones? Does it strengthen your bones?
Does protein strengthen bones? We'll get to that when we talk about osteoporosis, okay. But the short message is there are 19 different ingredients to make strong bones.
Okay.
Nutritional type ingredients. Probably the biggest thing is stress. You know, when you walk,
right.
I mean, your body adapts, right? Good question though. Yes, ma'am.
Are they still recommending that vegans take a supplement of B12?
Yes, we'll get to B12. We're going to talk about D today and B12 next week. Because B12 is more related to the problems with B12 has to do with more of the mental stuff. But B12 is the only supplement that you can't get in your food or by catching a little sunlight for vitamin D. Loss of height. So they did an autopsy, and so this is an x-ray. And you can see your vertebral bodies here, and you've got these disc spaces in between. And those are, when you sort of lose your height as you get older, it's not these bones that are coming together. It's these disc spaces that are getting narrower. And these disc spaces do not get a blood supply directly. The bones get the blood supply by diffusion goes down to the disc spaces. So basically narrow discs is a nutritional disease. They did autopsies on 70 and 80-year-old people in Scandinavia, and they found that the people with the most narrow discs had the blocked middle lumbar arteries and sacral arteries coming off the aorta. Getting back to the blockage sort of situation. I used to tell people that was just wear and tear. I was wrong. Again. Yeah, the list is long. So supplements, we'll talk about B12 next week, but I wanted to talk about D because I always wanted to be around when they found something that some other value for sunshine other than vitamin D that it did. And everybody knows about vitamin D and the bones and everything like that. And the immune system's been pretty hot. But it also, you have nitrates stored in your skin. And when you get sun exposure, it releases the nitrates and creates nitrous oxide. Does this sound familiar? Your blood pressure actually goes down when you're in the sunlight. So the skin stores bunches of nitrate-like compounds, and then the UVA, not the UVB, but the UVA light liberates those. And so you can take supplemental vitamin D if your D level is low, but that doesn't give you this value. So the best way to get your vitamin D is sun exposure. Do I have a dermatologist in the room?
Don, our time is up. Did you want to give people a break so
Yeah.
they could go to forum and
Yeah,
the ones
I'm
that
sorry,
want to stay can
I
stay?
forget. So let's, want to talk about fish oil real quickly. Fish consumption is associated with hair. Arsenic and mercury in your hair will tell us how much fish you've eaten in the last 2 years, because you can't eat fish without mercury and arsenic in it. It's not possible. Fish oil has been shown to have no effect on the inflammatory markers. I had a question about that. All the fish oil also contains carcinogens. So I want to hit you with one story, then you can leave.
Pressure, and after about a week, I have no blood pressure. Dr. Forrester said, stop telling people you have high blood pressure. You don't have blood pressure problems at all. I lost 22 pounds. And I just feel great. You know, we have people in this art group that we're in, and we all had an option. We could volunteer for this survey that, what is it, group program, And so most people didn't want to do it. Oh no, I'm not going to give up my meat. Oh no, I'm not going to stop going to Mickey D's. Oh no. But then after about a week, when they start seeing us looking good, feeling good, getting off the meds, and just driving, shining, and so now they all want this program. And I'm saying, when are they going to do it again? I want to join. And they say, oh no.
Okay, so here again, your experimental one. And basically, it gets back to our favorite cartoon, right? So I'll see you next week. We'll get out a handout and we'll talk about the neurological disorders next week.
And where is the forum? Is it in the union?
Yeah,
The forum, question where the forum is, it's in the union, I believe.
Yes.
Yeah.